hopefully last ever virtual education symposium. We really felt like it was important, given the amazing work that's been happening across the school and the campus, to be able to, showcase the work that people have been doing. And I was reflecting this morning on how remarkable it is that this amount of work has been happening in the midst of 2 years of heavy clinical burden, pandemics, pay cuts, and all of those kinds of things. So I just want to say congratulations, and I'll say that several times throughout the day as people join in. I also want to say a special thank you to both Jody Wang and Erin McKay for their incredible support of this process, both in making sure that it could happen, that we could still have a symposium, even in the midst of the pandemic, and also in helping to facilitate coordination of all of the moving parts that take place this week. So very much thank you, Jody and Erin, for your continued efforts in this. All right, with that, I'm going to turn it over to you, Lauren, to share with us your Stepping Stones poster.
Awesome. Thank you, Shanta. Good morning, everyone. My name is Lauren Anderson, and I am a pediatric hospitalist at Children's. And this morning, I would like to share with you a faculty development project that I've been working on over the last 18 months. It's called Stepping Stones, which is really aimed at supporting the early career hospitalists within my section. Before I dive into the details of my poster, I want to share kind of how I landed in this realm of faculty development. And that really was based on my own experience transitioning from trainee to faculty, where I felt, very comfortable and confident in my ability to go take care of patients at the bedside, but felt pretty clumsy in how to approach the rest of my job as an academic physician, what the expectations were of me, what I needed to do to set up myself to have a career that I would be happy with and proud of. And so with that in mind, kind of dove into this project. When I first started thinking about Stepping Stones and the idea of supporting early career pediatric hospitalists or providers in general, I started by going to the American Academy of Pediatrics, which is kind of our holy grail within pediatrics, to look for any advice or input they have. And while I didn't find an answer to what to do, they made it clear that what I was after was important. So they emphasize within their mission statement that early career pediatric faculty should be engaged and connected in order to optimize their professional fulfillment and ultimately retain these individuals within the field of medicine. As I then thought about who within my group would qualify as early career, I assumed it would be a large number. The national trend across pediatric hospital medicine has been growth. And in actually crunching the numbers within our group here in Denver, found that over the last 6 years, we've grown 145%, and just over 2/3 of our faculty qualify as early career, meaning they're either instructors or assistant professors in their first 10 years of practice. As I reflected on my own experience that I shared with you and then spoke with these individuals, it became clear that adequate support to launch your career was missing, at least within our group. And therefore, I started on this journey to try to improve that. Specifically, based on what the AP suggested, I was really interested in how additional curriculum might be beneficial to improve professional fulfillment, autonomy of these early career folks, as well as their connectivity. And in diving into the literature, really didn't find much in the way of career development curricula that focused on this aspect of things. So with this project, my objective really was to assess the interests in, as well as develop, implement, and evaluate a career development curriculum for early career pediatric hospitalists. My methods followed Kern's 6 steps for curriculum development. So starting with a needs assessment, which I administered via an electronic survey to the 24 early career members of my group. And then once those results were in place, I started to develop and implement a curriculum called Stepping Stones, with the core of that really being a seminar series as well as professional portfolio creation. And then thinking ahead towards my program evaluation strategy, I identified some validated indices to get at my aims to measure fulfillment, autonomy, and connectivity over time. And those two indices are the Stanford Professional Fulfillment Index, as well as something called the Basic Psychological Needs Work Scale. Diving into my results from a needs assessment standpoint, I was pretty happy. There was a large number who were unsure of what their end goal was, particularly as it pertains to academic promotion. And you can see the specific statistics below. When I then asked them what within faculty development was important to them and what they felt like they needed, career development was the most highly rated subcategory of faculty development. And when the respondents then rated current offerings within faculty development, as you can see, they weren't viewed highly. So only 16% felt that current offerings were very good or excellent. And finally, asking my respondents who would be interested in participating in a new curriculum if it were made available, all but one said they were interested, citing specifically the opportunity to have an up-to-date professional portfolio, as well as a clear vision of their career as kind of top motivators to join. So with this information, I then set about creating this curriculum. I found some content experts, because I'm certainly not an expert in any of these topics as an early career faculty member myself, but found some content experts to help me develop seminar sessions that were built to be very interactive, with time for self-reflection and a lot of small group discussion rather than being truly lecture-based. As far as the topics for these seminars, those were developed based on additional results from my needs assessment. So there were some additional questions that asked folks to rate their current competency in a variety of kind of academic physician skills, as well as rate topics within career development that they thought would be most valuable. And based on those results, I came up with these 6 sessions, as you can see on the left. So goal setting and faculty ranks, career development plans, engagement in career goals and requirements, mentorship, representing your work, primarily focused on CVs and dossier building, and then networking. And based on these, I also developed a template for a professional portfolio with components that correlate with each of these sessions. And you can see kind of how that correlation works by that color coding on the left. After this was in place, we then went about recruiting our first cohort, which happened kind of late summer, early fall of this past year. And we're excited to have 9 early career pediatric hospitalists interested in participating. They did take those validated indices that I mentioned before ahead of session 1, and to date have completed about half of the curriculum, as you'll see denoted by the green checkboxes. Their 4th session, the one on mentorship, is in just a few weeks, and they will finish up with that 6th and final session come June, so kind of following the academic schedule. After each of these seminars, I do administer a survey to all members of the cohort, really asking for their feedback on, what went well, what didn't go well, what would they like to see changed, as well as some more directed questions to better understand if we were successful in achieving our specific learning objectives for each seminar. And I've been very happy to see that, generally speaking, people have been pleased with this curriculum thus far. The data I have so far is pretty limited, but based on these post-session surveys, each respondent for each seminar has rated the seminar as either very good or good. And when asking folks to reflect on what was the most valuable component, the theme has been pretty clear that people are most interested, kind of topic aside, in the opportunity for reflective practice as well as conversation with their colleagues. And you can see some of the specific comments related to this theme in that blue table down in the middle of the screen. So in conclusion, to date, with the work that I've done, it's clear to me, at least here in Denver, that career development support is needed among early career pediatric hospitalists. And while Stepping Stones is still very much a work in progress, it is proving itself to be a promising means to promote career development and support these early career faculty. We hope to build on our early successes as we complete this first cohort's curriculum and then think towards recruiting future cohorts with the goal of having a new cohort every academic year. Thinking more long-term, my hope would be to kind of refine this curriculum based on that feedback. We will also be measuring those validated indices at the end of the curriculum and then about 6 months out for the first cohort, with hopes of identifying kind of larger impact of this curriculum. And as we get that information and build additional cohorts and kind of develop a larger data set, I hope to refine this model into something that would be beneficial to other early career faculty across institutions and across specialties. And with that, I will pause and take any questions.
Great, thanks so much, Lauren. I'm going to have you have Dr. Kubicek switch out for the next poster while I just ask a quick question about, that was really fantastic. And I think a lot of us are going to be interested in those results around fulfillment and the applicability. I see Juan Lessing on here to adult hospitalists. Would there be something similar in terms of the benefit that they would receive from participating in a program like this? And I also wonder about maybe doing a control group of people who are not doing it and just watching what those fulfillment engagement scores look like over time if they're not participating. And then I bet nationally, long-term, there's going to be an interest in losing people. What does retention look like with a program like this? And are you making an impact and even some possibilities, I'm sure, for interinstitutional collaborations, both on the adult and pediatric side. So.
Right. And I've been in conversation with some folks on the adult side, and I didn't mention here since I don't have the results, but we do have a control group for those. Okay. So we'll see how they do. Yes.
Awesome. Thank you so much. That was really well done. And just so everybody knows, if you see me typing, I'm just taking a few notes, hopefully to be able to share. That was fantastic. All right, Lorraine Kubicek, are you ready to go? Thank you.
Yes, I am. And can you see my poster?
Yes, it looks terrific.
All right. Great. Thank you very much. So, whoops. Hi, everybody. Happy to be here today. So my name is Lorraine Kubicek. I'm a developmental psychologist, and I am at JFK Partners in the Department of Pediatrics. And I'm here today to tell you about our Project Scope, which is a national training initiative supported through the Administration for Community Living in the Department of Health and Human Services. And it's a national training initiative to support and train around opioid addiction and its impact on children and families. So just to begin so I can get through this. So throughout the United States, including here in Colorado, sure you're all aware that opioid addiction and overdose are having devastating consequences for children and families and communities. And that being the case, there really is a tremendous need to identify, screen, monitor, and also provide interdisciplinary care and support for the vulnerable children and families who are affected by the crisis. So Project Scope, and SCOPE stands for Supporting Children of the Opioid Epidemic, involves a national training initiative to build interdisciplinary provider capacity and confidence in applying evidence-based practices in screening, monitoring, and interdisciplinary support for young children and families impacted by opioid use, trauma, or related exposure. And so our trainings use the ECHO model, which stands for Extension for Community Healthcare Options, and is an all-teach, all-learn telementoring model that uses case-based learning, led by expert teams through video conferencing or on Zoom. And, I have to say, when we applied for this funding in early January of 2020, it sounded like such an innovative idea. And of course, months after that, we have now spent the last 2 years doing this in so many aspects. But again, there are some special qualities to how ECHO works. And our SCOPE series includes 8 weekly 1.5-hour sessions that are appropriate for an interdisciplinary audience. And so, various topics that we have include introduction to the opioid crisis and social determinants of health, and also impact of trauma on child development. The basic format that we follow, we have a half-hour expert presentation, followed by a short case presentation. Then we break out into small discussion groups to discuss the case, and then come back again for a large group discussion. And a primary goal of, the ECHO model and of this project is to really reduce health disparities in remote and traditionally underserved communities by closing gaps in access and delivery of training and services. So another highlight of the ECHO model is that all of our sessions are free, and we simply ask attendees to complete a short evaluation survey after each session. And what I'm going to share with you, what we have in our poster here, these are evaluation data from our first series, which launched about this time last year. We also had a second series in the fall, and now we're in the midst of our third series. So we did attract, in doing this, a multidisciplinary audience. So our attendees include, early care and education providers, healthcare providers, infant and early childhood mental health specialists, home visitors, parent educators, special service providers, case managers, administrators, families, and members of the judiciary, among others. And these folks came from 33 different zip codes in Colorado that ran mostly along the I-25 corridor. So you can see in that map that we have in the upper right-hand corner. And for this first series, our attendance ranged from 28 to 48 participants. And if you look at our survey responses, I think you can see that attendees were very satisfied with these sessions. So in terms of, questions about the usefulness of the training, whether it was relevant, whether the learning objectives were met, case presentation being useful and relevant, and also, the session contributing to their understanding of how the opioid crisis is impacting children and families. So all of our responses here ranged from 92 to 100%. People responded that they also feel this helped to connect them to other professionals in the field. So here the ratings were a little bit lower, but again, over 80% up to 96%. And then what we found interesting here is, approximately 75% of our attendees said that they, are working or have worked with a child who's been exposed to opioids. 16% said they didn't know, but then, we asked the question about prior training. Just a little over 50% of those people have had, previous training about how opioids impact children and families. So in conclusion, we feel that our attendees were very satisfied with these trainings that helped them feel connected to other professionals. SCOPE is achieving its goals of filling a gap in knowledge about the opioid crisis and its impact on children for those working with children and families impacted by the crisis. And, moreover, SCOPE has also increased access and delivery of training to caregivers, as well as an interdisciplinary group of professionals in various geographic regions of Colorado, including some that are more remote and traditionally underserved. And like I said, as you can see, folks that attended, really range from north to south along the I-25 corridor. So we're happy with that. And we have found that, with each subsequent training, we are, kind of increasing our reach across the state. So we've been happy with our results. So yeah, if anybody has any questions, happy to.
Great, Lauren. This is, as a non-pediatrician, this is really interesting in terms of the potential impact on child health across the state. And I wonder if there are, the educational piece of it seems extremely successful, but I wonder if there are hard outcomes that the group or others are looking at in terms of amount of interventions that are happening or number of children who are experiencing this.
Yeah, no, that, we, like I said, we're just focusing on the training. And so our only, connection with folks is during the trainings that we're doing. So they come for these 8 sessions and that's it. So don't really have anything beyond that. We're really looking at the impact of, how many people we reach, where they're coming from, and how diverse, our audience is. So.
From that perspective too, I wonder if you'll notice an increase in outreach back to you for support or help, if you will see an uptick in people reaching back out.
Yeah, a little bit. Like I said, people are very, very interested in this. And, the funding that we have for this is short term. So that is something that we're looking at, because every time we do another series, we've had over 100 folks participate. We do have a Canvas course that goes along with it. So we put up all of the materials and people have, ongoing access to that. So, so people seem to be very happy about, having this available to them. So. And in our last series, we were able to pull in people from the Attorney General's office in the state, and that, kind of provided a really interesting perspective as well for everyone. So that wasn't part of our original, but so something we hope to continue to go forward with. So thank you. Thank you for listening.
Thank you. And similar to my question to Dr. Anderson, I think about applicability of this to other types of problems that people may be experiencing. All right, so I'm going to ask you to stop sharing. We're going to stay on course. Dr. Awadallah is here. Nida, thank you for joining us. Good morning.
Good morning. Thank you as well. Hopefully you guys are able to see my screen here.
Yep.
Awesome.
Great.
So I'm Nida Awadallah. I am a family physician here at the university, and I also work as the director of remediation in both GME and at the medical school level. Sorry, let me just reposition this real quick so I can get to my notes. So my poster today is called the Development and Implementation of a Novel Physician Wellbeing Leadership Fellowship for junior faculty. So this was a fellowship that we developed. Our N is only 1, it's very small, but we developed it for one of our, we call them 4th-year fellows. They're non-ACGME accredited fellows. Really, they're graduates of residency who pursue faculty development for a year. Our fellow was Robbie Martin, and he had a strong desire to do his fellowship in well-being, physician well-being and provider well-being. And so I'm here to really just talk about the curriculum that we did with him. And so we all know physician burnout adversely affects healthcare. In 2019, the National Academy of Medicine's consensus report on burnout noted that the problem was so widespread that leaders should be compelled to make immediate and widespread commitment to promote provider well-being at a systems and individual level. As we know, at least 50% of physicians suffer from poor well-being at some point in their career. We know that COVID has made this worse, with more than 60% noting that their burnout has increased since COVID started. We also know that training opportunities to address these needs are very limited. We are offering training at the resident level, and there are modules that physicians could take, but the kind of delving in deeper is very limited. And those programs where there are fellowship opportunities are very small and very difficult to get into. And so Robbie's goal was to make his own, and I think he did a really good job at that. And ideally, we could address this challenge by training physician leaders to specialize in these skills before they go out into practice. And so we developed a 1-year junior faculty program in September of 2020 through the Department of Family Medicine. Our goals for our fellow were to summarize and apply literature around well-being, observe, design, implement, and evaluate interventions to promote well-being at the individual and organizational levels, and also develop leadership skills to champion systems level change. We modeled our program on 4 pillars to include the teaching component, leadership, scholarship, and mentorship components, so that our fellow could graduate with important skills, both from a well-being perspective, but also as a leader and educator on the topic. The components of the actual curriculum were centered mostly around personal and human well-being, really at the individual level. We found early on that to be able to implement things kind of at the, at the systems level, if you don't do them personally, it's really hard to be able to be a champion for that. So that was kind of the basis around all of this. Moving on to physician well-being as the second kind of main part, followed by quality improvement, intervention design, and communication and leadership skills. The fellowship was largely self-study, including components of all aspects of well-being, to include things like mental health, burnout, self-compassion, but also things like sleep. And then some of the leadership aspects we incorporated as well, including things like emotional intelligence training. And then we also incorporated a scholarship component where our fellow worked with another family medicine program, helping them with their well-being curriculum, as well as developing this curriculum. And then also aspects of teaching, curriculum design, and mentorship. A lot of the self-study was done on his own time. This was a 50% clinical FTE and a 50% fellowship. And so much of the time was spent in self-study with monthly check-ins with myself, other faculty, I think Dr. Patrick is on this call, and mentors in the field of well-being. There was also a fellowship didactic curriculum, which we offer to all of our junior fellows, our junior faculty fellows, that included leadership topics and quality improvement topics and research topics. There was also a leadership training with a leadership coach. Our fellow had opportunities to be a leader in educational activities, as well as attending institutional leadership meetings, outside educational conferences, networking with a wide variety of wellness professionals, and then participation in scholarly activity. Our one fellow came into this, and his time was paid through an FQHC, and Dr. Patrick can spend more time on this if he wants, but my understanding is that it was his clinical site and his clinical time paid for that other FTE for the fellowship. But Robbie really wanted to be a provider wellbeing specialist in his new job after this fellowship, but that wasn't the intent of the FQHC to start. But after the fellowship, he was able to actually take it to the same FQHC and say, hey, I have this training. I would love to be in this role for your institution. And they did hire him as a provider wellbeing specialist at the end. And we did a follow-up survey. He noted that he felt like he was able to fill this part in his new job in both the personal and organizational level to champion systems level change. The most helpful aspects he thought included the self-study, again, which was a large portion, networking with wellness professionals and attending outside conferences. And we just wanted to present this as a model to equip other junior faculty with some tools and expertise necessary to combat this crisis.
Great, thank you so much. I agree, this is a great proof of concept, and I'm already thinking, like, how does this link to the continuum of medical education? So we have a curriculum for our undergraduate medical students that's building on leadership, and I know some residency training programs may be doing that. I see Dean Rumack on the call thinking about how is this generalizable to other of our GME programs. While you respond to that, maybe stop sharing. I'm keeping us on time. I see Alexis is on the call too, so we could get Lexi's poster up next.
Sure.
So Lexi and I actually switched.
Oh, okay, sorry.
Christine Seiler. I'm a cardiology fellow. Let me share my screen.
Go ahead, Nita. What do you think about the continuum? I know you work with medical students too.
Absolutely. I know that this can be easily replicated to really anyone. And I think it would be great to, if somebody doesn't just do a specific month or year, we are incorporating pieces of this in our junior faculty program across the board. And so I think it could be pieces, the most important pieces could be replicated really anywhere in training, in UME, as a fellowship, as a month, again, just kind of picking the most important pieces out. But I think it's really important. And there's so many pieces of this outside of just kind of the typical burnout. that I think are so important, like self-compassion, or what role does really sleep really play in our education and our learning, that we kind of just brush over, and in our well-being, And so I think there are some really important concepts that could be incorporated throughout all training.
Yeah, I wonder about a book club too. I know we've had some leadership type of book clubs or experiences. If we could do cross the continuum, so that more senior people were giving, tips or ideas or at different stages of training as well. Obviously, the types of stressors that we have are slightly different, but often overlapping, depending on what stage we're at and what stage in our lives and our careers. And then the other thing I just wanted to put a bee in your bonnet is that we have a new senior associate dean for faculty affairs and leadership development coming, and this would be something that would be right up their alley. And Dr. Rumack typed into the chat also about connecting with Dr. Jaiswal, who's leading the Wellbeing work in GME. So
Absolutely.
All right, a lot of bang out of that one person. Thanks.
Yeah, thank you.
All right, Dr. Saylor, you're up next.
All right. Can you see my whole screen?
Yes.
Okay. So again, I'm Christine Seiler. I'm a third-year cardiology fellow, and I'm excited to share with you guys the preliminary results from a cardiac arrest simulation curriculum that we designed this past year. And this was targeted for internal medicine residents rotating with us in the cardiac ICU. So we all know that in hospital cardiac arrest resuscitations at academic institutions are frequently led by our resident physicians. And really, when they are called to respond to a code, we're asking them to implement infrequently used technical skills, as well as non-technical skills. So things such as leadership and communication skills in an emergent situation with an ad hoc team with whom they've never potentially worked and may never work again. There's growing evidence that reinforcement of our ACLS skills every 2 years is really insufficient to maintain high quality resuscitation practices. And recent studies have demonstrated that brief, repeated, in situ or workplace-based resuscitation training, such as the curriculum that we designed, may lead to improved skill retention over time. We performed a needs assessment in May of 2021, with 56 respondents and 46% of internal medicine residents overall, increasing to 95% of PGY1s at the end of their first year of training, reported feeling unprepared to lead a cardiac arrest resuscitation. So we developed a 1-hour monthly educational intervention for the residents who are rotating with us in the cardiac intensive care unit. We bought a Preston Series 2000 CPR mannequin and the Simple app, SIMPL app, for use in the cardiac arrest simulations. So the curriculum schema in the bottom left corner of the poster there, outlined in red, there were 3 code simulations. After each simulation, the educators model what a code debrief should look like and provide residents with specific feedback as to their performance. Following each code, we emphasize a few key teaching points that we want them to understand with PowerPoint slides. Outlined in gray, you can see immediately prior to and upon completion of the educational intervention, self-assessments of resident confidence were obtained using a 5-point Likert scale questionnaire. Outlined in blue, skill performance was assessed during the first and the last simulation using a standardized rubric, which I've outlined briefly to the right of the schema. Details, if you want to look at more details regarding the simulation scenarios we use, the didactic teaching slides, and our methods of evaluation, you can scan the QR code there on the bottom. It links to a bunch more information. So a total of 7 educational interventions have been completed to date, involving 42 internal medicine residents. Preliminary data from the skills assessment demonstrated in figure 1 there in the middle, significant decrease in time to first shock from 114 to 33 seconds. And in figure 2, significant decrease in interruptions in CPR, which we defined as the seconds off of the chest divided by the total seconds of CPR, decreasing from 18% to 7%. The resident and leadership and communication score, which we made up based on our rubric, evaluating them for 6 key components, increased from an average of 3 to 6 out of 6 on this rubric. Preliminary data from the questionnaire also showed consistent improvement in resident confidence. In figure 3, Following the intervention, more residents reported feeling somewhat or very confident to lead a cardiac arrest resuscitation, improving from 31% to 72%. Residents also reported feeling more confident to provide feedback on CPR quality during a resuscitation, order the appropriate medication, and specify the dose that should be given, provide high quality post-resuscitative care, and to discontinue a cardiac arrest resuscitation for futility. 100% of our respondents responded that the simulation curriculum improved their understanding of cardiac arrest resuscitation. So in conclusion, we feel like this 1 hour in situ, again, in the workplace while they're in the ICU, simulation really improved their confidence and their performance to lead a cardiac arrest resuscitation. Importantly, I think it also describes an effective low-cost alternative to high-fidelity simulation. I think that can be a stumbling block for some programs to get something up and running if they think they need to spend thousands and thousands of dollars to get a sim program in place. And the mannequin that we used was a little over $200, and that app is $10. So really effective teaching and an effective improvement in resident performance for a cheap cost. We haven't evaluated, it's been too short, how their retention of these performance gains, if this is going to be effective for that, but that's something that we hope to do in the future as well.
Yeah, I was going to say, awesome opportunity to measure their confidence at a later date, even maybe at the start of their MICU rotation or at their end of their PGY year or something like this. And I'm already thinking, like, how does this apply to potentially to our students who are getting ready to graduate in some of the base camp work? And I'll connect you with Anna Newmeyer around that, because I think it's a pretty impressive outcome. Any difference in patient survival? We always
no. What I really want, and honestly, what I think was the biggest take home point to me being a cardiology fellow is how long it took people to shock VT and how much we focus on staying on the chest, and no one wanted to shock until it was the pulse check because they didn't want to stop CPR. And it would be interesting to see if this would improve, at least from the in-hospital arrest time to shock. That's something that can be fairly easy taken from our monitors.
Yeah. Do we use the automated defibrillators at all in the cardiac unit, like where the machine decides?
No.
I think some of those interventions have been successful in delaying time to shock.
Yeah,
I remember having one of my jobs one time was to review all of the resident mistakes around this with a nurse and a video, and it was amazing to me how long it took them as well to go ahead and decide and do that defibrillation, which probably would hopefully
improve survival. Yes.
Yeah. Great though, and I love the leadership thing. I know Dean Druck just joined our call too, and I think we're thinking about a leadership rubric for our medical students as well. If you wouldn't mind sharing kind of what you all came up with, I think that would be cool for us too, to think about collaborating.
Yeah, absolutely.
All right. Thank you, Dr. Seiler. Next up is Stacy Staudinger. Dr. Staudinger, I think, am I right? There we go. Yeah. Hi, Stacy. Thanks for joining us. Looks good. Got it.
Good morning. I'm sorry. I did the check at the beginning, and then I'm still failing on the text side. Can you just see white, or can you see the whole poster?
We see white now.
Okay.
I saw the poster a minute ago.
For some reason, I've had some technical difficulties with this computer in particular.
I feel you. 2 years into this pandemic.
And I did even, kind of test run before this. How about we do it this way? Or maybe if somebody's right after me, I can kind of troubleshoot and come back. My
Would
apologies.
you, I pulled it out, your poster. Would you like me to share?
Oh, that's
the screen?
terrific.
All right. I got
Thank you,
it.
Jody.
You're welcome.
Yes, thank you.
No
Again, my
worries.
apologies.
Here you go.
So let's reboot. So I'm Stacy. I'm a physician assistant with the Division of Hospital Medicine. And I'm excited to share this work with you this morning. This is in partnership with several of my colleagues in the Division of Hospital Medicine. It's work around implementing a novel clinical reasoning curriculum for advanced practice fellows in hospital medicine. And so some of the background and origin for this work. So there was a National Academy of Medicine publication in 2015 that really was entitled Improving Diagnosis in Healthcare, that really called out the frequency and impact of diagnostic error, and identified and outlined kind of 8 key goals so that, those working to sort of move the needle in diagnostic error could sort of target their efforts. The first 2 of which were to foster and facilitate more effective teamwork in the diagnostic process, which includes, of course, the care team, but incorporating more intentionally the patients and their families. And then secondly, really focusing on healthcare professional education. And there was a good amount of other sort of systems-based level recommendations, but our project is certainly targeted to the more educational approach. There was some follow-up work by Dr. Mark Graber in partnership with the Society to Improve Diagnosis in Medicine. And they published an educational policy brief. And some of the most compelling points in that work were that they did a pretty expansive literature review and found that very rarely is clinical reasoning training explicitly taught in a comprehensive manner focused on, preventing diagnostic error. And in fact, one study they cited was a pretty robust survey of clerkship directors that found 84% of students entering clerkships had either poor or at best fair knowledge regarding key clinical reasoning concepts when entering the clinical phase of their training. And as you might imagine, we know kind of across the board that this aspect of education is presumably or probably deficient, but those deficiencies can be magnified in advanced practice provider training programs simply by the shortened training time, and also the sort of heterogeneity between different models. And so a little bit more about our group and our particular learner population. We have within the Division of Hospital Medicine an advanced practice provider fellowship that trains 2 cohorts a year of 6 fellows in who have already completed their degree and are practicing clinically, but they're focusing, of course, on acute care medicine. And so we sort of aim to bring this work in diagnostic related education to this learner population. And so some of the follow-up work within the Society of to Improve Diagnosis in Medicine led them to publish a consensus curriculum that outlines sort of key core competencies and then nailing that down to learning objectives in these realms. And so our faculty, through sort of an iterative process, took the most relevant objectives from that work and outlined a curriculum for our advanced practice fellows. We did do a needs assessment survey of a previous cohort of advanced practice fellows. And it's interesting, it sort of tracks along the line of what was sort of published in that previous work. And then also what we kind of see on the wards, right? That we're pretty decent at, like, in the apprenticeship model of teaching, how to formulate a problem representation and make a differential diagnosis, and some of those skills that are repeated in the context of clinical care in the wards. But some of the more advanced concepts that you can see in that table 1 on the right are things that were sort of not, sort of as a whole, but certainly in our curriculum weren't hitting very well. And so that seemed to sort of fit, what's been published on the topic, and certainly what we had observed within our own fellowship. So we organized the learning objectives for our curriculum into a series of 4 modules that were highly interactive, case-based, and done on or delivered on dedicated educational days so that the learners could have sort of focused time without interruptions from patient care or pagers. And then, one other element of our curriculum, in addition to sort of didactic and case-based teaching, was to provide the learners with skills cards. You can see an example there, sort of right in the middle of the poster, where after teaching certain content or skills, we gave them a card that was, somewhat could reiterate some of the concepts, but also was designed to have them apply those in the context of clinical care. And they could actually return those for a small coffee gift card. And so based on that was sort of the structure of our curriculum. And to date, we've taught this curriculum to our first cohort of learners. So that's 6 advanced practice fellows. And we'll begin the instruction for the next, based on scheduling, the next 2 cohorts very soon. Obviously, with having taught only 6 fellows, our data is not very robust to date, but as you can see here in the table 2 on the right, that our curriculum was quite well received. So the top half of that box there shows that the learner composite session rating. So overall, they felt that the material was very useful for their future practice and were satisfied with the educational session. And then sort of in the bottom section, reflecting on the entire curriculum, and these are scores on a 7-point Likert scale. So, sort of roughly 6.5 on each of these measures. They felt that the educational series improved their knowledge, their comfort level, and would improve their future care of patients. And so breaking down sort of where to go from here and some of the lessons learned, obviously, from a data standpoint, I think there are a lot of levels and layers that we could add in terms of multimodal assessment. In education in general, multimodal assessment is important, but certainly in this type of content area, I think probably more so. So that was really one of the more thoughtful and sort of labor thought intensive aspects of our project. And a lot of that hasn't really been borne out quite yet. But we do plan to add, as you can see in the box in the middle, on the very bottom, these different layers of assessment. So adding a follow-up survey, adding kind of some more knowledge retention type questions, and then really kind of trying to translate that into, how's the material observable in the context of clinical care. Scoring H&Ps, for example, with a structured rubric for clinical reasoning, or doing a direct observation activity with actually the Society of Diagnosis in Medicine to Improve Diagnosis in Medicine has an assessment of reasoning tool. So that might be a tool that we can use to provide additional feedback and also see to what degree the content that we're presenting gets incorporated into the actual care that the providers are delivering. So, as you can imagine, and as I've briefly discussed, assessment in this realm is, sort of notoriously difficult. I think some of the thought leaders in this area have commented on, perhaps this is why diagnostic quality was a sort of late arriver to the quality game or the quality improvement effort, because I think it's a little bit harder to sort of discreetly teach and move the needle. For example, a lot of the skills that we try to teach have to do with reflective practice and have to do with, sort of internal cognitive or mental habits for, to bring biases in check, or to develop processes or systems of workflows to improve diagnostic safety. But certainly we feel optimistic that this is sort of an early but successful application of, some of the work of the thought leaders. to establish this consensus curriculum, and in the vein of improving diagnosis-related education. Certainly there's broad application for different learner populations, multidisciplinary populations of learners, groups of learners, and certainly across the continuum of, all the way from medical or advanced practice providers, schools and their preclinical training all the way through, professionals in practice. And so it'll be exciting to, kind of partner together and think about more broad applications. And, certainly to kind of wrap up, further research and, just more observational understanding of what we see with our own project is needed to kind of figure out the best educational best practices for clinical reasoning education, and how we can incorporate those concepts into, better assessment tools, better mechanisms for feedback. And then from there, how do we incorporate this content into entrustable professional activities, which is kind of becoming the way of medical education. So with that, thanks to Jody for sharing my poster. Appreciate your help and appreciate your time this morning.
Great. Thank you so much, Stacy. Really interesting project. And while we switch to the next presenter, congratulations to you and your team on this. It's something I think it is kind of that holy grail for us to try to figure out how we assess clinical reasoning. And I would love, I'm sure there are folks across the spectrum again who would be interested in looking at the rubric and trying to pay attention to that. Wearing my other hat in the Office of Diversity and Inclusion, I think about implicit bias and how do we incorporate a question about bias into a rubric like this, not cognitive bias, but am I thinking about this patient through the context of that, bias lens around diversity and equity from all kinds of protected identities. So great work. Thank you for that. Emily, you are next. And Emily, is it Angel or Angel? Make sure I say that correctly.
Angel.
Angel. All right. Thank you. Thanks, Emily.
Yeah. So my name's Emily Angel. I'm a third-year PA student at Anschutz, and I did this project with Dr. Ford at the Kemp Center at Children's. So this was really looking at sentinel injuries and how healthcare students learn about sentinel injuries, identifying and reporting them. And I initially became interested in this and realized that this was potentially an area of research when I spent a month with the child protection team and realized that, I had learned in my own didactic training about bigger types of child abuse, such as abusive head trauma, fractures, shaken babies, things like that, but not really about sentinel injuries. And for those of you who are less familiar, sentinel injuries are things that on their own are not really clinically significant enough to trigger a full workup or a child abuse report. So it's things like intraoral injuries, like a frenulum tear is really common, as well as different types of bruising. And there are really good evidence-based guidelines out there to identify which bruises would raise suspicion for being a sentinel bruise versus what types of bruises are just normal bruises. So there are really good guidelines out there, and sentinel injuries do provide a really unique opportunity to intervene. There are studies showing that of children who presented to the hospital with abusive head trauma, almost a third of them had previous sentinel injuries that were either not really worked up or not addressed and not reported. So it does present a really unique opportunity to intervene in situations that are potentially very dangerous for kids and to intervene at the level of a bruise or an intraoral injury rather than abusive head trauma. So sort of to prevent those bigger injuries. And while those guidelines exist, they weren't emphasized in my own didactic education. So I wanted to really do a needs assessment for other didactic PA students at Anschutz, evaluate if they have knowledge deficits and confidence deficits surrounding sentinel injuries and see if those can be addressed with really targeted intervention. So my population was the first and second year PA students at Anschutz, so the didactic phase students, and I sent them 2 surveys. The first was sort of that needs assessment, giving them different cases, asking them to just basically share their knowledge about these types of guidelines and a couple of Likert scale questions about rating their own confidence doing these things, followed with a survey, a lecture that I presented to them with different cases, sort of running through these guidelines, allowing them the opportunity to ask questions about these things. And then that was followed by a second survey to see if there was any change in performance. So as I said, there were sort of two domains that were evaluated, the knowledge domains and the confidence domain. So sort of, are they able to identify sentinel injuries and know when abuse should be on a differential, and how confident do they feel in themselves doing these things? And as you can see, just figures 1 and 3 are looking at the knowledge domains, and figure 2 is looking at the confidence domain ratings. And there is a pretty significant jump in performance following the lecture. And I really defined performance on the knowledge domains, like defined a deficit as a less than 70% performance. And in all of those cases, they showed a statistically significant improvement in performance after the lecture, and their confidence ratings really jumped up significantly as well, as you can see. They also gave some more qualitative type feedback, just what was helpful, what would they want more practice with, as this was sort of the first lecture of this type that they had received. So they felt that the cases were very helpful. They felt that sort of those evidence-based bruising guidelines, like the 10-4 faces bruising guidelines, were helpful in just knowing those smaller signs and sort of easier things for them to remember when they see it in clinic. They did want more information on the whole CPS process, like what happens when you actually do report, what is the process like, what are the steps after that, as well as wanting more cases. And then finally, they did express that they wanted some practice speaking with families about abuse. So when you suspect abuse in clinic, how do you bring that up to a parent? How do you say, I'm concerned for child abuse, and really practice having those more difficult conversations? So overall, they didn't show deficits in every area that I tested them on, but in all of those areas that they did, as well as in all of their confidence rating questions, they did show significant improvement in all areas following the intervention, as well as expressed really a desire to know more about these topics and get more practice with it. So I think taking those two things together, I think it shows that this targeted education and this intervention was really successful in impacting these students' abilities to identify sentinel injuries and report them and know the proper workup. So it did accomplish the objectives that I wanted it to. Obviously, there were some limitations, small sample size. This was all completely optional for the students. It wasn't fully integrated into the curriculum. And that sort of goes into what I would ideally like for next steps here. Just based on how successful this was, I think the immediate next step would be to try to integrate this content into the actual curriculum of this PA program. So not just a standalone lecture, but fully integrated, as well as really tweak the intervention itself based on those feedback items that I got from the students. So provide more case-based practice, as well as provide practice, like I said, speaking with parents and bringing up, I'm concerned about child abuse, and really giving students that opportunity to practice that they don't often have in their didactic phase or in their clinical phase until they actually come across it. Far in the future, really looking at other PA programs, potentially integrating something like this, as well as other clinical education programs such as MD or NP. But the immediate step, as I said, I believe is integrating this into this PA program's curriculum. And I am at this point going to present these results to the faculty of this PA program and hopefully speak with them this semester about integration of this content for next year.
Great job, Emily. Congratulations to you and to Dr. Ford for this outstanding intervention and also your presentation. Dean Druck had a comment in there about looking at the possibility of measuring an outcome on the amount of reporting. And I think, a lot of these students that sounds like you're describing are preclinical students, not as spending as much time yet in the clinical space, but maybe considering a quick intervention of giving them a tool and a refresher about how to report. And you might see an impact on the number of people who are reporting as they enter into their clinical phase. So cool next steps there. And of course, I'm already stimulated by wondering where in our curriculum map in the MD program are we putting this into place too. So excellent results, and I think a great opportunity to check this again later on in the curriculum to see if they're retaining the things that you taught them. What was the total number of your N there? I missed that.
So the pre-intervention survey was completed by 35 students, and then the lecture and post-intervention survey were completed by 17 students.
Okay, great. Thanks so much.
Yeah.
All right, nice job. Next presenter today is Grace Chandler. Hi, Grace.
Hi, thanks so much. I will share my screen. Just give me 1 second.
Thank you.
All right, is everyone else able to see? Perfect. So hi, thanks for having me. My name is Grace Chandler. I'm one of the third-year pediatric residents, one of the rising chiefs next year. I'm going to be discussing our project, employing reflective writing to gain insights from a resident teaching elective curriculum, actually on behalf of one of our pediatric second years, Savannah Brackman, who was the first author on this poster, and unfortunately couldn't be here due to clinical responsibilities. So thanks for having me in as a replacement. So together with Kim O'Hara, our project mentor, ourselves and some other residents who preceded us developed an elective, teaching elective for residents called Teach, and a rotation for residents particularly interested in practicing their skills as clinical educators on the inpatient wards. The basis of the elective is based on ACGME's recommendation that requirement that residents participate in education of learners and develop their practice. And obviously in an ideal world, there would be plenty of time for teaching in the clinical space by senior residents. Realistically, patient care and other scheduling demands can often limit this ability for residents to teach, and rarely allows for significant deliberate practice of these skills and actual observation and reflection on this as an iterative process. So in the Teach elective, residents will complete, and we have had about 30, I think now we've had more, but our N was 32 residents. But during the elective, residents will complete different educational activities, whether for anywhere from 2 to 4 weeks of elective time. The activities include readings and video assignments, direct observation and feedback to learners, and then actually getting feedback, sort of getting feedback on their ability to deliver feedback and to the learners by attendings, either to dedicated teaching attendings, chief residents, or the wards attending on service, and then participate as well in small group teaching. So designing those teaching sessions and actually implementing them. Residents, then we asked all the residents who participated to complete a post-course survey, which really comprised 2 parts. So first, an initial Likert scale questions, which we have previously explored in a prior abstract, and then this reflective writing component. And so our project was really looking at the written reflections to more robustly identify themes in the residents' experiences. So while we had convincing sort of self-reported Likert scale data describing increased competence and confidence in residents' teaching abilities, what we really wanted to do was a deeper dive into the nuances surrounding this. And so qualitative work served as a better means for this, and still self-reported, but a little bit more robust and detailed. So 4 reviewers, first in pairs and then all together, coded the written reflections using basic interpretive qualitative methodology. So not the most robust way to code, but we did do it in pairs and then in a group of 4 to obtain consensus on these themes. And we identified themes as part of 2 major categories. So first, residents, participants as educators themselves, and then how they viewed the teach elective themselves, or how they viewed the teach elective itself. Regarding the residents as educators, the themes emerged in orange boxes that you'll see here. So a self-perceived improvement in teaching skills, a better understanding of the benefits of deliberate practice of these skills, utilization of more effective teaching tools, appreciation for learner-centered teaching, and then a longitudinal observation of learners and what it's like to work on a team and really be able to give feedback after seeing someone improve over time. And then affirmation of a career interest in medical education, which would be expected as this is an elective and it's self-selecting in many ways. Residents were overwhelmingly positive about the way they perceived the elective as developing their role as educators. And so I've included some of the salient quotes here, but we do have, as part of our larger data, sort of a repository of quotes that fit into these themes. As for the structure of the elective itself, residents appreciated having dedicated time to hone and develop their teaching skills. And that was sort of pretty universal among the written reflections, was this idea of having dedicated time outside of their clinical responsibilities to do this. However, they did identify this possibility of feedback fatigue if the elective was too long, revealing that maybe a whole month is a little bit too much time to be present on the rounds, both for learners and for the residents being kind of working with the same team. So through the use of narrative, we were able to gain new insights into self-reported behavior change regarding residents as teachers, and felt like, reflective writing can be a way to offer this insight in narrative medicine to evaluate future curricula and in similar sort of spheres, having asked people to do that. So whether that's through reflective writing or reflective interviews, just a little bit more of a qualitative approach. I think a natural next step becomes, how do we objectively rather than subjectively measure behavior change? And so we have pretty good data, both from this study and from prior evaluation of our survey data, but it's really all self-reported. And so I think we believe that direct observation of residents as teachers, either before and after teach, or using a cohort of residents who have not elected to participate in teach, might be the best way to remove this sort of self-reported bias and self-reported self-selection. Another possibility is sort of an OSTI type scenario. So actually doing some direct observation with a standardized learner. We would definitely welcome any suggestions for future directions pertaining to this work. But that's really what I have for you today. And so thanks for your time, and I'm open to any questions or suggestions.
Thanks, Dr. Chandler. Have you thought about looking at student evaluations of their resident teachers?
Yeah, so I didn't mention, because it's a little bit out of the scope of this project, but actually last year we did look at the specific evaluations, both from students and learners, and then from the ones I mentioned where you're getting feedback on your feedback. So we had part of the elective is there are 2 different types of evaluation forms. So direct observation of teaching evaluation, which is called our DOTE, and then direct observation of feedback, which is called a DOF. So we actually looked at that last, and that did show, it showed that residents were sufficiently doing a good job of teaching and doing a good job of delivering feedback. And we measured that sort of as checking certain boxes of what is deemed as as specific and actionable and high quality feedback. The issue with that prior work was that we really didn't have a comparative group. So there weren't DOTs and DOFs being performed or obtained prior to the elective. So it was hard to evaluate the elective itself as the specific causal behavior change. And so, and just that was sort of the data that we had. And I think it's definitely so we definitely have incorporated those student evaluations, but it might be nice to have sort of either cohort it or have students fill out those evaluations prior. I think some of the limitations with that might be the limitations in time. And if you're not on the dedicated elective, how much teaching are you actually able to do? But it's definitely a possibility. And I think that's a great thought, but just would wonder about how we could kind of like demonstrate that this was the cause of behavior change.
Yeah, causality would be difficult. I love your idea of having feedback in an OSCE situation. I've been in programs before where we incorporated that into medical student OSCEs. The medical student does the history taking, the resident gives the feedback, and then the attending comes in and says, good, here's your feedback on your feedback. I love that meta concept. Can you just maybe expand on feedback fatigue and what that was like for your folks, and then we'll get going to the next presenter after that.
Yeah, sure. So that was one of the things that a few of our residents identified was this idea of, having a resident on the rotation for a long period of time, trying to give feedback every day. Sometimes there was a perceived sort of fatigue involved in this, both and obviously they weren't in the position of the learner, but they felt like, learners got a little tired of kind of getting feedback every single day, which sort of counters this idea of an appreciation of longitudinal observation of learners, because you can get so much from really observing a learner over time, but then kind of having that dedicated teaching role every single day was this sort of idea of feedback fatigue. So it wasn't a universal theme, but it was just one that we wanted to consider rather than just talk about all the great things people said about the elective.
All right, great. Well, congratulations to you and your team. Thanks for representing, and nice job. Okay, our next presenter today is William Aaron Manning. Let's see. Aaron, see you there. Thank you for sharing.
Hey, everybody. Can you guys see the poster here?
Yep, looks great.
Awesome. So I'm Aaron Manning. I am one of the MedPeds hospitalists. So I split my time between Children's and the university. And I'm going to present a project that I worked on with the other folks listed here on the slide, where we looked at implementation of a point of care lung ultrasound curriculum for pediatric hospitalists. So a little bit of background, as many of you all probably know, point of care ultrasound, or POCUS, is becoming more widely implemented both on the adult side and now on the pediatric side. And point of care lung ultrasound in particular is very useful in pediatrics, given the frequency of respiratory illnesses that we see, as well as its demonstrated ability to diagnose pneumonia just as good as, or in some studies better than, chest X-ray. So based on that data at Children's, our pediatric emergency medicine faculty are actively being trained to use lung ultrasound to evaluate patients for pneumonia. We have a number of providers, PIM providers, that are already using lung ultrasound pretty extensively for this patient population. But on the other hand, at least prior to the start of this project, our Children's pediatric hospital medicine providers really didn't routinely employ ultrasound, nor could they interpret or acquire images. And so we kind of postulated that if PHM providers were not comfortable using the PEDS emergency medicine lung ultrasound results to inform their decisions, that they would be more likely to order additional imaging on pediatric patients and communicate poorly with PIM providers and with patients regarding the clinical importance of lung ultrasound results obtained in the emergency department. And we actually saw a couple of kind of real world examples of this prior to the start of the project, where patients were admitted that had a diagnosis of pneumonia based on a lung ultrasound finding, and our pediatric hospitalist really being unable to interpret those findings or explain them to families, would then get a chest X-ray to either confirm or refute that diagnosis. And as you can all imagine, we felt like that was poor care for a variety of different reasons. And so we actually kind of approach this problem more with a QI approach using educational interventions. And so our global aim was to improve the care of children hospitalized with lower respiratory tract infections by training PHM providers to interpret lung ultrasound images and understand their clinical significance. And again, we used a multimodal educational QI project consisting of 2 different interventions in the pilot phase that I'm going to present here. And our educational goal was to provide PHM hospitalists with the knowledge and skills necessary to use previously acquired lung ultrasound images to manage a pediatric patient presenting with suspected pneumonia. So for our curriculum, in our first intervention, 11 PHM hospitalists watched a 40-minute online video that I created to teach interpretation of lung ultrasound images. Then about 2 weeks later, in a second intervention, the same 11 hospitalists participated in a 4-hour hands-on lung ultrasound training workshop, teaching lung ultrasound performance. In this workshop, we did a lot of skill practice with standardized patients. And then shout out to Chad, who I saw on here earlier, for TSP. We used priming and retrieval practice, which I had no idea we were actually using at the time because I wasn't in TSP yet. But we did priming essentially by putting our participants through a very short OSCE of sorts with standardized patients before the training to see if they could actually demonstrate lung ultrasound acquisition skills. And then essentially did retrieval practice by putting them through that exact same OSCE after the workshop to make them recall all of the things that we had taught them over the 4-hour workshop. For data collection, hospitalists were surveyed prior to the video intervention, and then prior to the hands-on training intervention, and then again after the hands-on training intervention. So that gave us our results here, where you can see the first graph on the top left. We asked providers how able were they to identify a consolidation on lung ultrasound. So this was all self-reported. You can see pre-intervention, the majority of our participants said that they weren't at all able to do this. That shifted to the majority saying somewhat able after watching the video. And then after our workshop, the majority of our participants said that they were fairly or very able, with everyone else saying somewhat able. In our next graph, top right, we ask whether or not providers agreed with the statement that they had the knowledge necessary to review lung ultrasound findings with peds emergency medicine colleagues and with families. And similarly to our first graph, you can see that pre-intervention, essentially all of our providers strongly disagreed with that statement. And then that shifted to after the workshop, all of our providers saying that they agreed or strongly agreed with that statement. Moving on to bottom left, we then ask our providers just to rate their comfort in terms of their ability to use lung ultrasound to actually manage patients. And you can see pre-intervention, providers not at all comfortable. After the video, kind of a mix of not at all comfortable, somewhat comfortable, with some saying that they were now fairly comfortable. And then after the hands-on workshop, the majority of providers felt fairly or very comfortable using lung ultrasound to manage patients. And then the most intriguing graph to me is bottom right, where we essentially gave our providers on these surveys 3 hypothetical clinical scenarios in which a peds emergency medicine provider had used lung ultrasound to evaluate for pneumonia. And then we asked providers what they would do with that information. We asked whether or not they would start antibiotics, continue antibiotics, but then pertinent to this graph, whether or not they would order additional imaging to confirm or refute those findings. And you can see pre-intervention in about 40% of those scenarios, so 33 scenarios total, 3 for all 11 providers. So 40% of those scenarios, providers said that they would order a chest X-ray. After watching the video, that dropped significantly to 20%. And then after the workshop, that number dropped all the way down to just 3% of scenarios in which providers said that they would order a chest X-ray. So just to get into our discussion, the last couple minutes here, we took from this that virtual education increased self-reported ability to identify consolidations and communicate lung ultrasound results with PEM colleagues and families. We also showed that providers were able to demonstrate high proficiency on just testing of lung ultrasound principles and image acquisition. We did include 14 multiple choice questions, and the average score went from a baseline of 59% up to 87% after just the video intervention. We didn't repeat this after the hands-on training. And then, as you can see from the graphs, we showed that while the video was helpful, the hands-on training definitely provided an additional benefit, particularly in regards to potentially decreasing chest X-ray use. So in terms of our next steps here, we would love to actually compare the real-world frequency of chest X-rays ordered by lung ultrasound trained versus non-lung ultrasound trained PHM providers on pediatric patients at Children's. And then would love to expand the hands-on training to the entire section of Peds Hospital Medicine and see if we can replicate these results with the entire section. That's all I got.
Great. Thanks, Dr. Manning. There's a question from Dr. Druck. Do you have any data on clinical implementation? Wonder if ED providers felt like this interaction changed the discussion, or how often the ultrasound was reviewed together with the hospitalist. So maybe.
Yeah, we don't right now. We would love to move in that direction. So kind of full disclosure, this was all kind of contrived at the very start of the pandemic. And so we were hoping to, one, have a lot more providers in the PEDS ED that would be using lung ultrasound, and have essentially more opportunities to see what happened with those patients. But COVID essentially cut some funding for ultrasound training for the PEDS ED, and so they weren't able to roll out that training as quickly as possible. And then, as everyone who's worked at Children's knows, our pediatric patient population numbers dropped pretty precipitously for quite a while. And so we had nowhere near the number of patients presenting with lower respiratory tract infections that we thought that we would, at least over a year-plus period of time. And so we kind of pivoted to look more at what people would do in hypothetical clinical scenarios. We did recently resurvey our entire PHM group about 2 months ago, after experiencing a pretty heavy fall respiratory season at Children's. We just don't have those results yet.
Thanks, Dr. Manning. One last question. I'm a dinosaur, and so these data probably do exist, but I'm not aware of them. How different is listening with a stethoscope compared to ultrasound in the pediatric population for identifying a lower respiratory tract infection?
So I would say the data on using clinical exam findings to diagnose bacterial cap show that we're not very good at doing that clinically, and we probably way overdiagnose bacterial cap. Yeah, if that kind of answers your question.
Yeah.
Lung ultrasound is probably better than that, but it's still controversial in some areas.
Grown-ups have bigger chests, obviously, than children do.
Yeah.
Okay. Thanks for your presentation and for this work. Nice problem to have that there's not enough cases of lower respiratory tract infections, I guess. And now we're going to move to Dr. Madsen's presentation. Dr. Madsen is joining us virtually. Is that right, Jody? You're going to share for us? Thank you. Or I guess everybody's joining virtually. Dr. Madsen is joining from France. So welcome. Bonsoir, I guess.
Probably bonne nuit.
Maybe, thanks. Yeah. Helen, can you hear us? See, Dr. Jaiswal, you're a co-presenter. It looks like, oh, there we go.
I can talk about the work if Helen doesn't log on, or I can't tell if she's logged on.
She says she can hear us, but we cannot hear her.
Oh, yeah. Okay. We can't hear her. Maybe she's muted.
Yeah, I think she might.
I think you're muted. There we go.
Can you guys hear me now?
Yep.
Yes.
Perfect.
Can you hear me?
Yeah.
Oh, yay. Sorry, I have no idea. This is apparently very complicated over here. Okay, so my name is Helen. I'm one of the fourth year general surgery residents in my research time, and I'll be presenting our work on longitudinal integrated clerkships in medical students. So a little background for this study. I'm sure most of you are familiar, but a longitudinal integrated clerkship, or an LIC, is a reimagination of the core clinical year, most commonly the third year in the medical student training. Rather than doing the traditional discrete specialty blocks, such as 8 weeks of surgery, followed by 8 weeks of internal medicine, students will be working in specialties simultaneously. So they are assigned a preceptor within each specialty that they follow throughout the year, as well as following a patient cohort throughout various clinical experiences. For example, if a patient goes to the emergency department, they can see them there and then follow them back to the primary care doctor and then to the surgical operating room. And in this way, they're participating in all of the different specialties at once, rather than in a block setting. And this LIC model has been around for a while and is gaining popularity and has been showing really positive findings for both faculty and residents, with good training for the medical students in patient-centeredness and empathy, and adequate training for student skills and knowledge, especially surrounding shelf exams. So it's been overall pretty positive findings in the literature. But there has been some concern from the surgical side, just mentioned in the literature, and then anecdotally that we have seen at our institution, about surgeons being concerned about the adequacy of the LIC to provide surgical training for medical students. So we really wanted to understand this from the surgical faculty and resident perspective. So we performed a survey of the faculty and residents at our institution. The survey was distributed.
Hang on one second.
Yeah.
Jody, we lost the poster. Hang on. Yeah.
Oh.
All right.
Of course.
Go ahead. You can go ahead. We'll get it back.
Okay, thanks. So we distributed this to all of the surgeons in our department, and it was a 16-item anonymous survey with various types of questions, everything from yes, no, Likert questions to open-ended questions. And our goal was really to understand the experience of surgeons with the LIC and their understanding of the LICs. So you can see our results in the middle. In the top right, our response rate was 22%, or 88 out of 402 people. And on the left, I'm going to jump over to the left for a second. You can see the demographics. So it was 47 faculty, which was 58%, and 34 residents, which was 38% of the respondents. When asked if respondents understood the difference between TBR, and just to explain, TBR is the block curriculum, so the traditional curriculum. If they knew the difference between a TBR and an LIC, most did. About 68% understood the difference, but only about 40% on the bottom had previously taught LIC students, so less than half of the survey respondents. And then jumping down to the bottom left, we kind of wanted to know how well surgical faculty and residents feel that they know students at this point in the curriculum. And one thing I forgot to mention is that, of course, the University of Colorado is switching over to an LIC curriculum to be implemented throughout the medical school. So we're kind of in this nice transition phase where we're seeing a lot of the traditional curriculum being turned over to an LIC curriculum. So we're getting a good glimpse of what surgeons feel about students right now when we are not in an LIC curriculum before we switch over. So at this point, before being in an LIC curriculum, surgeons are reporting that they have either a limited knowledge of their students' skills or just a general knowledge. And only a few surgeons were reporting that they knew students well enough to tailor instruction, and only even a smaller amount knew students well enough to provide mentorship to them. And then as well, when we wanted to ask about the skills that students are taught in the curriculum, we wanted to understand how well surgeons felt that students are currently being prepared by the curriculum in the third year. And essentially, you can see the means are typically between 2 and 3. 2 represents students being good at the skill, and 3 represents them being somewhat good at the skill. So for most of these things, the surgeons feel that the students are good to somewhat good, which is less than ideal. And we, of course, would want to see these numbers closer to 1, which would be very good. So the lower the number, the better the student is prepared. So in various skills, the surgeons had relatively low confidence, including performing informed consent and interpreting imaging for surgical diseases. And then finally, when asked if surgeons felt that the LIC or the TBR curriculum would be giving better surgical training, they overall leaned towards medical students receiving better training in the TBR curriculum with a 5-point scale, and the mean being 2.87, and 2 is on the side of being better in the traditional block curriculum. And then in the free text section, they were able to mention a lot of concerns, and this was actually utilized quite often by the respondents, and they brought up various things, but the lack of having an immersive surgical exposure was brought up quite frequently by respondents, as well as the concerns about lack of broad specialty exposure, and that the success of a student would be dependent on that student's individual drive and characteristics. So in conclusion, we found that overall surgeons had a low baseline knowledge or prior teaching experience with the LIC, and that currently they have relatively low confidence in student skills at the end of the surgical clerkship, and few surgeons at this point are getting to know their students well enough to tailor instruction or mentorship in the current model. Despite all of that, there still remains a bias towards the traditional model, and many surgeons are concerned that the LIC will not adequately represent the surgical experience and prepare students. So we found that this would be very important for our curriculum as well as other curriculums to kind of understand what surgeons need to be educated about before an LIC rolls out. So mainly focusing on facts such as the idea that the surgical skills and exam skills are going to be similar in these two curriculums, and that students, for example, on shelf exams perform the same or better as their TBR counterparts. And that there are also shortcomings in the surgical education that can be addressed by an LIC, such as getting to know your student well and understanding the skills that they have, so you can really tailor those, the teaching in order to fill those gaps. And that is it. If you guys have any questions, let me know.
Great. Thanks, Dr. Madsen. I think we're going to be looking forward to follow-up data that shows the comparator group once we make that transition as you're suggesting. Is there an idea to repeat the survey even in this hybrid year that we have now, where we're going to have a larger number of students in the LIC model, so there could be a comparison between TBR and LIC students in the same cohort? Or maybe
exactly. We are planning a follow-up survey.
Okay. Fantastic. It's very interesting to see how badly the skills are rated at this point, which from an intervention perspective gives us an opportunity for improvement. So I'm going to say glass half full there. All right. Thank you. And thanks for joining us while I assume you're on vacation. I appreciate that.
Yes. Thanks for the patience with the technical difficulties.
All right. Great. Thank you. Dr. Scott is next on our presentation list.
Shanta, I'm going to have, good morning.
Good morning. Yeah, Jody can show your presentation.
Yeah, I'm going to have Charlie Lockwood, one of our fourth-year residents on this poster present. And
awesome. Welcome, Dr. Lockwood. I see you on there. Great.
Yep, okay.
Dr. Scott, do you want me to share your screen, or do you want to?
I can pull it up.
Okay.
I'm happy to pull it up if it's easier. So just give me a minute.
Either way.
Yeah. that look okay to you all?
Yeah, perfect.
Very good.
Thank you.
Yep. Okay, so I'm Charlie Lockwood. I'm one of the fourth year orthopedic residents, as Dr. Scott said, from the CU Department of Orthopedics. I'll be presenting on our formal orthopedic surgery boot camp to improve performance on acting internships. Introduction wise, orthopedic surgery is highly competitive specialty in NRMP residency match, as we all know. Literature shows performance on acting internships historically is the #1 predictor of residency match success in orthopedics. And with step 1 moving to pass fail, acting internship will likely hold an even more weight. In 2019, we developed a senior medical student 4-week preparatory class to be attended prior to acting internships. The purpose of this, we call it the boot camp. So the purpose of this orthopedic boot camp elective is threefold. 1, improving basic orthopedic knowledge, clinical skills, and operating room skills. 2, preparing our University of Colorado fourth year medical students for outstanding performance on their acting internships. And 3rd, to improve CUSOM match rates and first choice match rates in orthopedic surgery. Moving on to the methods. So as we said, we created this 4-week intensive curriculum. It specifically includes general orthopedic didactics, practical clinical skill development on the floor in emergency room situations, anatomy and surgical skill development, utilizing fresh frozen cadaver prosections, experience in the operative theater, small team-based group learning case-based discussions and individual case presentations. In order to evaluate the students, we individually evaluated them through #1, a 50-question pre and post elective or boot camp standardized multiple choice tests written in the orthopedic and training exam, OITE exam fashion. This was created to objectively measure improvements in orthopedic knowledge. Secondly, we evaluated through clinical performance, specifically course director survey results from the students' away rotations and performance evaluations. It's funny, we sent one of these was a standardized form from the School of Medicine to say how our students did, and the other was a survey we created to ask how our students compared to students from all other institutions by those program directors at the different sub-internships or acting internships. And then lastly, we evaluated through operating room performance based on course director survey results. So moving to the results, we did the program director survey. This is the blue, orange, and gray chart you have there. And you can see that our students were judged or thought to be in the top quartile for knowledge, clinical performance, and operating room performance. And so that was based on the program director survey, and then the external performance evaluations, this being the CUSOM form that was sent. We were in the top 6. Our students were in the top 6 for medical knowledge and clinical performance. In terms of general orthopedic knowledge, using this 50 question test I talked about earlier, the first thing we did, we wanted to make sure that both versions of the test were equally difficult. We found that there was no significant difference in the 2 tests when they're taken either as a pre or post test. Secondly, we wanted to know, did the students improve their fund of orthopedic knowledge by taking this elective? And our results showed, yes, they did. A significant improvement in their test scores. Thirdly, we wanted to know, are CU students on par with away rotators in regards to general orthopedic knowledge before taking the boot camp course? And this was actually a little bit surprising. It was no, there was a significant difference. And you might ask about when did I consider time 0? So time 0 for CU students was before taking our boot camp class, and then time 0 for away rotators was before they did their sub-I at CU. Sorry about that. And then next was, do CU students have more knowledge than away rotators going into their first sub-I after taking the course? And we found yes. So again, considering it time zero now before sub-internships or acting internships, our students scored significantly better than students coming in. What I failed to mention earlier was we gave the same test before and after every acting internship at CU for the away rotators as something to gauge our students against. And then finally, did the away rotators gain orthopedic knowledge from their CU sub internship or acting internship? And interestingly, this was no, and that plot at the very bottom, the away rotator scores versus rotation, shows this graphically, that they really did not gain any orthopedic knowledge or significant orthopedic knowledge during any time during our sub-I season. And some of these students, this was back before the pandemic, had done 5 or 6 away rotations, and they still didn't have an improvement of knowledge versus not only the first group, but during their acting internship. So this was somewhat concerning, and gives another reason why I think it's really important that we're doing this, is that there's a chance that students are not gaining a lot of information on these sub-internships. They are just trying to prove that they are worthy of being picked for the match. And if they're not getting a ton in medical school and they're not getting a ton during their sub-internships, and then they're jumping right into residency, there's going to be a discrepancy there and a very, very steep learning curve. And we're hoping to decrease some of that. So some of the conclusions, I touched on some of them already, but to go back through them. The orthopedic boot camp objectively improved CU ortho-bound students' fund of basic orthopedic knowledge by way of those tests. CU students have less orthopedic knowledge at the end of their MS3 year compared to away rotators. After completing the boot camp, CU students have a better fund of knowledge going into their first sub-internship compared to away rotators. The program director survey showed that CU students are in the top quartile in regard to orthopedic knowledge against their peers from other institutions. Formal performance evaluations of our students consistently have them scoring in the 5 range, which correlates with outstanding fund of knowledge. In terms of clinical performance, program director survey showed our students ranked in the top quartile, as I said earlier. Formal performance evaluations showed that our students, again, were in the 5 range, meaning organized, complete, efficient HMPs and communication skills with minimal need for resident or attending input. In terms of operating room performance, program director surveys also showed our students in the top quartile. The course utility, basic orthopedic knowledge does not improve over sub-internship season, as I've showed here, and making pre-sub-internship or acting internship knowledge base and clinical skills, I think is vital to not only match success, but transition to residency and residency success. And I'll open it up to questions.
Thanks. Thanks, Dr. Lockwood. Quick question and a little bit longer one. Quick is the N of students that you had in the 2 categories. And then the second question is, given what you found out in this, would you recommend not having acting internships in orthopedics?
That's a great question. So the N, I think this data is just based on the first year we did it. However, I've looked at at least on this slide, I've looked at the data from last year, 2021 as well, and it correlates exactly the same. So that's an N showing this data of about N of 24 of our students versus even more of away students. I think it's like N of 40 of away students. The 2020 year was complicated because there were no rotators from the outside. So that data doesn't really, it's not as comparable. In terms of whether sub-internships should happen, instead of saying we shouldn't have them, I think that nationally they need to be restructured to be more about education. They seem to be more about show up, work hard, don't get in the way, be pleasant, ask questions at the right time, and less about, hey, this is the 4th year of medical school and we need to gain musculoskeletal knowledge. So I think it would be very hard to show that you're worth something to other programs if we got rid of sub-internships at all, but they're definitely, they're not doing the job.
Yeah, thanks. Although we did have a year without them, really, didn't we? Okay. Yeah, interesting food for thought. Thank you so much for presenting. And I hear you're busy in the OR too, so I appreciate you breaking away to be able to do that. Our next presenter is Dr. Rachel Clofton.
Hello. I'm just going to share my screen quickly. Okay, can everyone see my poster? Yes, okay, excellent. So my project is called Cardiovascular Physiology Revitalized. I am a pediatric cardiac anesthesiologist at Children's, and I'm also the course director of cardiovascular physiology for the CU School of Medicine Anesthesiologist Assistant Master's Program. So basically what an anesthesiologist assistant is, the way I like to describe it is an NP is to a PA what a CRNA is to an AA. So it's sort of like the PA equivalent of in anesthesia. The program is a 28-month master's program after they complete basically similar prerequisites to being a pre-med. And they transition immediately into jobs. So there's no post graduate training after this. It's quite an intense program, and cardiovascular physiology is routinely ranked as the most difficult course in the curriculum. So when we went completely virtual for spring 2021, several weaknesses were exposed in the cardiovascular physiology curriculum. So right now, prior to these interventions, it was basically 16 two-hour lectures that I gave once a week, every Friday, sort of very similar to a college type course. The grades were based on the midterm and the final with no checkpoints in the middle. And in 2021, the midterm average was 77% with 4 students failing. And prior to that, in 2020, the midterm average was 84% with no students failing. I've been teaching this course since 2017, and this was by far the lowest performance I've seen on a midterm exam. The AA program leadership also set a goal to transform the curriculum to 80% active learning by 2026, so these changes fit with that. Basically, my objective of my project was to develop, implement, evaluate, and assess a more active curriculum for cardiovascular physiology in the AA program. So I used the Kern's 6-step approach to do this. And the first thing I did was I created pre and post lecture quizzes. So this was a total of 24 quizzes. And this is to emphasize both priming and re-emphasizing important material at the end of the course or at the end of each lecture. I also altered the traditional lectures to incorporate more review questions at the beginning and to in the spirit of interleaving. The major changes I made were I developed 2 PBLD round robin sessions using the Nooks platform. And this platform basically allows students to be placed into rooms, and there's a document in each room. And students can move back and forth around the rooms, but the document stays in each room and it's editable. So in each room, there was a PBLD. And the students were split into 4 groups, and there were 4 rooms, and they rotated around, and basically each group of students answered a portion of 4 PBLDs. So over the course of roughly an hour and a half, we were able to go through completely 4 advanced anesthesia scenarios with each student participating in each different scenario. The other change that I made was I created Jeopardy style games using another platform called Factile. So I made one specifically for EKGs, one for midterm, and then also another one for the final exam. I also made them fill out post-lecture surveys after every lecture. And routinely I would change things. So after the first PBLD session, I made several changes to the structure based on their suggestions. So as far as evaluation and assessment, so evaluation, so metrics comparison, for the midterm exam, final exam, no students failed. And the performance on the midterm exam was similar to performance in the past. It was roughly 85%, I think, was the average. So they dramatically improved their performance on the final exam compared to the midterm. And more importantly, no students failed. This is especially important because if they fail a course in this program, they're out of the program. So failure is a really big deal. And the fact that several students failed the midterm was a big problem. They all went on to pass their national certification exam with 100% pass rate. But this has been consistent ever since before I've been teaching in the program. I don't think we've had a student fail the national certification exam. I mean, since at least probably 2014. The students also really enjoyed the new learning curriculum. They enjoyed the new, they enjoyed the quizzes. So what the quizzes did is the quizzes brought the percentages on the midterm and the final down 10% each, and 20% of their grade is based on the quizzes. And the quizzes are open everything. They're open note, open book. They can do them together. I don't care. I just want them to go through the material and figure out the answers. They also rated the new system as much more enjoyable, especially the PBLD learning sessions. They keep asking for more and more and more. So I think we're getting to a point now where I'm still going to make some more changes for next year. So I'm teaching this course right now. And one of the things I've realized, especially with the EKG topic, which is very dense, it's about 5 hours of lecture material, is that I need to put more stopping points where we stop as a group and go around and interpret EKGs together, instead of giving them a whole bunch of information and then stopping and doing a review. I need to review more frequently, especially with a dense topic like EKGs. And I think that is about all. I'm very anxious to see how this group performs on the midterm. They'll have their midterm on the 11th of March, because in my subjective view, they seem like they're struggling more than any class ever. So we've actually had a couple of extra review sessions for them. And I really hope that they do well, but I'm honestly awaiting that objective data. So we will see. And that is my presentation.
Thanks, Dr. Clopton. Great outcome. And I wonder if this is generalizable to some of the other courses within the curriculum, and if your colleagues are going to take this, steal from you, and develop some of these similar things for the other courses as well.
Thank you.
All right. Next presenter, we have Sunny Cotter. We're almost staying on time here today. Thanks, everybody.
All right. Hello. How's it going?
Hi. Good to see you.
All right. Let me make sure this is full screen. Oh, let's see. Are you all seeing the slide itself?
Presenter view.
Oof. Okay. No, that's not what we want. Give me 1 second.
Just swap. There you
go. Yeah, let me just unplug it from my other monitor.
If you just change, if you go to new share, and then you share the different screen, the other screen.
All right, let's do that real quick. While I'm doing that, I'll just quickly introduce myself. So my name is Sunny Cotter. You'll see Neil written on the poster. Neil's my real name. I'm a medical student at Oakland University William Beaumont School of Medicine in Michigan, but I'm on a research year right now within the Division of Plastic and Reconstructive Surgery. And I'm going into my 3rd year in a couple of months. And I'm a Colorado native. I went to the University of Denver, so it's been really great being home for the year. And so I think everyone's seeing the full slide right now. It's no longer just the presenter view. So I'll go ahead and get started. Oops, and there we go, another thing. Okay, so All right, great. So to give a little background about this project, so here at CU, the plastic surgery inpatient service is managed by first-year residents from a variety of different surgical subspecialties, including plastic surgery, general surgery, orthopedic surgery, urology, and ENT. If you look over to the far right, you'll see the distribution here for this study. We have an N of 30. So 26% of the people in this study were integrated plastics, 26% were orthopedics, 22% in ENT, 11% general surgery. For prelim, 11% categorical general surgery, and then 4% urology. So essentially, as the service is managed by this variety of different specialties, we wanted to look at just different outcomes after the rotation on the plastic surgery service. And so here we aimed to educate residents on the essentials of plastic surgery, enhance the experience on the rotation, and improve patient care through the use of plastic surgery inpatient service guide. And so this service guide is probably of most interest, especially for this conference. Essentially, we put together a guide, and this, when I say we, I mean the residents who've been here for years, have been putting together a guide that essentially outlines all of the different preferences of each surgeon. For example, what kind of sutures they tend to use, what kind of dressings they like to use, how to navigate the different hospitals that they'll be working at, and then just convenient things like parking and places to go eat around the hospital and things like that. So this guide was used for the residents and was kind of our additional variable in this study. So here we hypothesize that the guide will improve resident understanding of key topics in plastic surgery, in addition to being on the service. So our methods here, like I said, we had a total N of 30, of which we had 25 out of those 30 actually complete the pre-survey and post-survey. And so the goal of the survey is to determine the resident experience within different key topics. And it was a Likert scale that ranged from 1 being no prior experience or knowledge to 5 very comfortable managing that specific key topic individually. So the guide was distributed at the beginning of the rotation and provides information for procedures an intern would be expected to complete. And like I was saying, preferences of the surgeon and just miscellaneous resources that could be of use. So if we turn our attention to the results section of this poster, you could look at the different areas that we were evaluating. So preoperative evaluation of pressure sores, looking at simple incision and drainage from an abscess at bedside, administering local anesthesia, removing drains at the bedside, performing various suturing techniques, bedside aspiration, evaluating whether a drain output is concerning. So is the output too high, too bloody, purulent, etc. Assessing viability or the take of a skin graft, troubleshooting problems within a skin graft donor site, applying or changing a wound vac, performing wet to dry dressing changes, evaluating postoperative breast complications like seromas, hematomas, infection, evaluating whether a wound is infected, and then assessing a flap, otherwise known as a flap check. And so a 1 was no prior experience or knowledge, a 2 was some knowledge, but no firsthand experience. A 3 was comfortable managing it with minor verbal instructions. A 4 was comfortable managing it independently, except in complex cases. And then finally, a 5 was just being very comfortable managing it independently. So as you can see here from pre to post, there's a clear shift from kind of a lot more light blue to a lot more dark blue. So people came in with, some experience with some things. It was completely a foreign concept. Some things there was some comfort coming from, medical school rotations. But towards the end of this 4-week rotation, a lot of people, and in fact, 100% of improvement was seen across each of these different key topic assessments. So our conclusions here were that rotating on the plastic surgery service contributes towards making residents more confident across each area assessed. 100% of them felt that way. And I feel like that is more of a obvious conclusion. Naturally, if you spend 4 weeks doing these things, you are going to get more confident. But one unique addition to this rotation was the inpatient guide that served as a useful resource throughout the rotation and contributed towards the success of residents across several specialties here. So our future directions here are kind of multifold. One is we should specifically look at the progression of residents in different specialties. So this is a combined assessment, but we should tease out, okay, how did urology feel specifically to these? How did ortho go? How did ENT go? And really try to tweeze out those specifics. The next thing we want to look at is producing more data specific to the usage of the guide itself. So here we're assuming that the guide was used and implemented, but our survey did lack in that it didn't necessarily ask how much the survey was being used and just how helpful it was found to be. And finally, I think one really great step we could take with this project, and something that would be of interest to me being a medical student, is assessing the use of the guide for fourth year medical students rotating on the service. And I think definitely handing it out to CU students or students rotating from a different institution. I think this would really help kind of, decrease the amount of stress that goes into scrubbing in with a new attending every other day while you're on an away rotation. But, knowing, oh, I'm working with, Dr. Washington today or Dr. Mathis, and I know that they would like me, like they always close this way, they always suture this way, and they always dress the wound in a certain way. And those are little things that you could just take out of the equation while you're obviously already very stressed out trying to perform well on your away rotation. So I think initially this study has shown some pretty promising and interesting results, and going forward, I think we just need to further kind of investigate some of these other cohorts. So thank you all for your time, and happy to answer any questions about this.
Great, thanks, Sunny, for your presentation, and congratulations on your work in your research year. One of the things that I think about is actually combining you potentially with Dr. Lockwood's presentation earlier about the boot camp that prepares folks for this. And I know you're in Michigan. There, colleagues over at the University of Michigan have done some extensive work on these types of pre-clerkship and pre-internship actually boot camps across the way. So it might be a place that you could collaborate and get some cross-institutional work as well.
Definitely, the boot camp plus a guide would be a great idea.
Yeah. All right, great. Thank you so much. Our next presenter is Dr. Nikki Nguyen.
Hi, everyone.
Thanks for joining us.
Thanks for everyone hanging in there. I will try to stay on time. So my name is Nikki Nguyen, and I am part of the Denver Health OBGYN faculty. And thanks for allowing me to share this study with you all. So does implicit bias training make a difference? A 6-month follow-up. Clinical performance evaluations have a significant impact on clerkship grading, which subsequently affect a student's competitiveness for residency. Studies have shown that racial disparities in medical student evaluations exist, leading us to evaluate our own institution. We all know that clinical evaluations weigh heavily into assigned student grades, and unfortunately, our analysis showed that we too have racial differences in the proportions of underrepresented minority students receiving honors grades during their clinical clerkships. So our objectives were to identify interventions to mitigate racial bias within our medical student evaluators by providing implicit bias training, or IBT. To examine the effects of IBT on participant understandings of implicit bias concepts, as well as using IBT to mitigate the impact of implicit bias on student evaluations. So our methods were, we asked grading committees to attend an IBT specifically designed for them. And these trainings involved real life implicit bias instances, which the medical trainees experienced, and ways to mitigate or intervene. Participants completed immediate pre-training, a 24-hour post-training, and a 6-month post-training knowledge-based surveys. And these survey items were rated on Likert scales. And on our 6-month survey, we actually had a few qualitative questions as well. Percentage of the responses in the 2 highest categories were reported. And we used Wilcoxon-signed ranked sum test p-values to report and assess the change in paired pre and post-test responses. So 56 participants completed the IBT. And when looking at the pre-training survey, about 98% of participants completed their survey. About 2/3 reported they had previously attended IBT. However, 94% only sometimes or rarely recognize racial microaggressions when they occur, and only 9% completely understood the term stereotype threat. When we looked at our immediate post-training survey, 64% of participants completed that survey, and 75% felt that IBT was very or extremely effective. And when looking at this graph below, we compared group level responses on the pre and immediate post-survey response. We found no significant change in the recognition of negative impact of microaggressions on URM student clinical performance, but did find significant differences on the appreciation of negative impact of stereotype threat or racial bias on URM student evaluations, and also a significant increase in the likelihood of evaluators to intervene when they observe bias in conversation about students or observe a microaggression against a student or a team member. Participants also felt significantly more prepared to mitigate their own biases in medical student evaluations, and improvement in the ability to mitigate their racial bias in their evaluation of medical students based on this training. When we compared the pre-test and the 6-month post-test response, 16% of participants completed all 3 surveys. Of those who completed all 3 surveys, 100% of the ratings for feeling prepared to mitigate their bias in medical student evaluation remained the same or increased at 6 months compared to the pre-training IBT. 100% of the respondents who completed all 3 surveys did show an indication of an increasing trend after 6 months and feeling prepared to mitigate their bias in medical student evaluations. We had a qualitative analysis on a question that we had asked, which asked respondents to describe a situation in which they applied any technique from the IBT to their approach in their evaluation or discussion of students during grading committee meetings. Being more aware of one's own bias was a common theme in the comments, and the self-awareness was applied during grading meetings, as well as grading and writing their own evaluations of students. Some respondents were actually tasked to identify bias during grading committees and to identify sources of bias in either just the discussion or the review process. And they also encouraged each other to point out when stereotyping or biased language was used. Several specific strategies were also mentioned in our qualitative analysis, such as removing photos of students, changing the order in which the students were discussed, and asking an important question such as, would this have been said if the student was of another gender or race? Overall, the comments reflected respondents were more aware of bias in both themselves and in others. They were able to identify bias in evaluation comments and have tools to mitigate when participating in committees, including being able to have discussion with colleagues. A lot of the comments don't specifically mention the IBT training. However, they do highlight that improvements in identifying and addressing bias in student grading and evaluation processes. So in conclusion, implicit bias training can be effective in changing attitudes and participant understanding of topics related to implicit bias. And 6 months after IBT, at least 75% of respondents maintained or increased their rating on being prepared to mitigate their bias in medical student evaluations. The impact and effect of racial microaggressions or stereotype threat on URM student clinical performance, and their likelihood of intervening when they observe microaggressions or bias in conversation against students or other team members, and the amount of improvement trainings on DEI topics have on their ability to mitigate racial bias in their evaluation of medical students. So, one of the major limitations was our low response rate and participants who completed all 3 surveys, therefore limiting the generalizability to the entire group who participated in IBT. However, when looking at kind of the themes, the idea of the role of the grading committee in identifying or bringing up bias is a fascinating one we'd like to kind of look into more, because it's a much more manageable way to target grading committee members than to actually target every single faculty member within the School of Medicine to complete racial IBT on medical student trainings. So I'm hoping that the future steps is that we will follow differences in grades between our URM and non-URM students to determine if interventions like this can reduce and ultimately eliminate racial differences in medical student evaluations. I just want to say thank you to my collaborators. I was fortunate enough to work with some powerhouses within medical education, Dr. Zimmer, Dr. Luxpizer, and Tracy Yamashita for really helping me go through a lot of this analysis. Thanks for your time.
Thanks, Nikki. one question, I struggle with this is that our data that show that we have disparities in the outcomes between our URM and non-URM students is actually disappears when we control for the shelf exam, suggesting that maybe it's not the clinical grading that is the issue, but something else related to the shelf performance that is contributing to this. And after doing this, obviously those data are emerging at the same time. It makes me wonder if this intervention would be predicted to impact that. I think, as somebody who cares about students, obviously I want faculty to be comfortable addressing microaggressions when they see them. And I think being an upstander is an important thing for us all to become more comfortable with. But I worry that it won't impact the outcome around grading that maybe was intended. What are your thoughts?
Yeah, I did look at that data. The one thing that I do feel is still impactful is that a lot of times, at least, as we're reviewing application from residency, we also will look at just clinical grades as well. And sometimes, in our holistic review of grades, we do see that there is just kind of racial bias just within standardized tests. And one of the things we've tried to do in our holistic review of applications with students is to really look at their clinical performance, because a lot of us feel that clinical performance really predicts success versus than just objective data a lot of times on tests. Not to say that they're not important, because we all have to pass boards, but I do, in our review of students, the clinical performance does weigh heavily. And so, based on this kind of subjective data and the evaluations, I'm hoping that that will help kind of close some of the gap within the clinical evaluations versus their objective data on their standardized test, if that makes sense.
Yeah, and I think one thing I want to give kudos to the Office of Student Life here at CU is that they do separate out that clinical grade so that if you're evaluating a CU student, you can see very clearly in their MSPE how they did on that clinical performance, which allows people to kind of tease that out. We're just about out of time, but as you know, nationally, there's this movement towards going away from having grades at all during the clinical core. I currently much prefer the approach that you've tried to take, which is to decrease the biases in that grading and try to make us do a better job in our assessment of students.
Thank you, everyone.
All right. Thanks, everybody. Thanks again to Jody Wang for her support of this heroic effort. We have several more sessions throughout the week, and this afternoon we have the TSP graduations. There will be oral presentations tomorrow. I know this poster session was like rapid fire oral presentations. We'll have longer presentations of some of the ones that were selected by the review committee. So thanks for those of you who were able to join us, and we'll hope to see you again later.
Thank you so much, Dr. Zimmer.
Bye.
See you.